To have these options and to be so optimistic that we're afraid to do the wrong thing. For the hormone receptor negative patients, it almost feels worth it to be as aggressive upfront because I just don't know what that biology is going to do. And I think to your point about using our best drugs first, to me, it feels like that's where I have to do it. But I don't think that's a hard and fast rule. I think there are going to be patients with, especially those with significant disease burden, where I want an almost assured response as quickly as possible. And for me, doing that would be TDXD plus pertuzumab up front. Then I think we play it by ear a little bit. I think I'd probably set to maybe maximum response for those patients where I commit to TDXD plus pertuzumab up front. I don't know that I'd say, 6-ish cycles like we do with Cleopatra. For some patients, it might be 4, 6, 10. But maybe get them to their best response and then think about a maintenance strategy with one of these other targeted agents we talked about.
And then I guess the question will be, then can you go back to the TDXD? And again, I think that will depend on how that progression happens and whether we can do that or not.
Absolutely. I think that whole line of thought only works if you can go back and you have the confidence that it's going to work as well later on. And so hopefully we'll have some real world data that comes out of all of this when we inherently do what we think is right to guide us in that. Because if that's not true, right, if we can't revisit it after a maintenance phase, then that changes the whole conversation.
Exactly.
So one of the things that struck me when I was looking at the data is, again, these are international trials, and a lot of times patients don't get to the post-progression therapy, which may not be a problem so much in the United States. I have to think that at least part of it is access to drugs.
Yep.
Do you all have any sense of whatever comes after TDXD, it works as good or not as good, or there's a shortened PFS, or it's just the disease? We don't have any sense that one drug should be the next drug based on any data that I'm aware of.
No, I don't think so.
Okay.
Yeah, I don't think so. So I would hope that most of our patients have access to ADCs after if you don't start.
In the U.S.
In the U.S., yeah. But I guess you're always taking that chance that like a patient could have very rapid progression and you don't get to that second line. But I think that's much more of an ex-U.S. phenomenon than we're going to see in our practice.
And are you thinking there is the possibility that if you went to maintenance, you could come back to TDXD, which you guys already talked about. But if you didn't do that, would you be doing HER2 climb or would you be doing something else?
Like TDM1?
Yeah.
I mean, again, I think it depends on the patient. And how they're progressing, CNS metastases, things like that. But I think it depends.
Yeah.
And ease of administration, one's every 3 weeks, one's, a whole bunch of drugs, some oral, some IV.
Yes.
So all those things go into the mix.
Yes.
Well, I think we captured what I was hoping we would, and that is just to get your all impression of DB09 and sort of a historical perspective. Anything else you want to leave us with before we close this session?
I think we can just say that this is a good problem to have these options and to be so optimistic that we're afraid to do the wrong thing is, not really a place that I expected to be with these metastatic patients. And so there's a lot of hope here. And I think, just sharing that decision making with our patients who are very, very savvy, understand this stuff, because they'll have thoughts. And I think we've got to respect that for the time being, especially when there's uncertainty of really what the best path forward is.
Yeah, I mean, I think it makes our job a little bit harder, but it's a good thing because we have these options that are producing better outcomes for our patients. And this really just brings us back to sort of the art of medicine. There may not be a specific algorithm that we have to follow, but we have to be doctors and have shared decision-making with our patients.